Stephen is a health policy and research consultant who is based in Saskatoon, and he's an adjunct professor of health policy at the University of Calgary and Simon Fraser University, where he was visiting scholar from January to April 2007. Stephen spent 7 years as CEO of the Health Services Utilization and Research Commission in Saskatchewan. He has served on many boards and committees, including the Governing Council of the Canadian Institute of Health Research, the Saskatchewan Health Quality Council, the Health Council of Canada, and the editorial boards of several journals. His published works cover topics such as reforming and strengthening Medicare, improving healthcare quality, primary health care, regionalization, and management of wait times. And today, Stephen's presentation is entitled "The Future Can't Wait, Health System Transformation in the Northwest LHIN." He'll provide us with a system perspective on change that is possible in transforming healthcare. Welcome, Stephen.
Thank you very much, and thank you for inviting me. And I'm sorry to cut short your break, but I will also cut short your day at the end, so you'll get this time back, I promise. It was a wonderful series of presentations. This is like a Shakespearean play. You know, the climax of the Shakespearean play is always in Act 3, which was before the break, and now you have me to wind things down to a clumsy conclusion and so forth, and leave partially depressed by having surpassed the climax some time ago. But I promised to try to keep you a little bit amused in this session. And my journey here was kind of like a metaphor for the healthcare system. You know, I'm from Saskatoon, and to my awe and wonder, you get here by going through Toronto. So you know where your target is, and you're right there in an hour and a half, and then 5 hours later you actually get here after having spent more money. So it kind of reminds me of how healthcare often works, but it was an interesting journey, and I like Pearson Airport as much as the next guy. I'd like to tell you that. I have nothing against it at all. So even though none of us presenters actually coordinated with each other previously while we were preparing our talks, I won't say that's a metaphor for the healthcare system. You can be the judge of that. But there is a continuity here, and there's a theme. And the theme is we will never get better unless we get the identification of the problem right. So the theme of this talk, and I'm going to leave you lots of room at the end for questions and comments, is essentially, how do you transform? And transformation is such a buzzword in healthcare now. People are getting jaded by it a little bit. So what are we talking about? Do we mean what we say? Is it the Canadian way to transform anything? And I guess my preliminary answer is we have a transformation problem in Canada, but I think we can probably do something about it. So, all right. Well, this may take a little longer than I thought if I can't advance my slides. There we go. So this is what I'm going to talk about. I'm going to talk about these things, and I will talk more about some than other. But I think to give you the punchline, in case you have to leave even earlier than I do, a lot of this is about culture. And I'm going to try to talk as concretely about culture as I can, because it's another abstract kind of ethereal concept. But I do think this is the heart of your opportunity here in the Northwest LHIN, and I actually think, and I'm saying this not because I'm here, I wouldn't say this in the Central Toronto LHIN actually, but I think you have an opportunity for doing a transformation because you have some natural advantages that you can capitalize on. However, the technology is defeating me. There we go. So why do we need a transformation? And again, I think most of this is known to you, so I won't belabor it. But as you can see, we have spent a lot of money trying to fix, quote unquote, the health and healthcare system. This has been the biggest cash bonanza in Canadian healthcare history in the last decade. And even though we now spend $82 billion more a year than we used to only 10 years ago, public confidence is still lower than it was in the 1980s. And whenever we measure the results, and I'll give you some of those results later just to give you the flavors, we're not doing all that well. We're doing a lot more stuff, we're doing it more expensively, but it's not necessarily getting us a payoff. So to fix the healthcare system, here's the things we've been doing for the last 15 years. And as you can see, they're unified by one conclusion. None of them worked. So we've spent less money, we've spent more money, we've regionalized. And I know one of the questions you have as I stand up here is, So, Steve, is the rest of the country making fun of Ontario because of the way we've organized the LHINs? And the answer is yes, but only behind your backs. But actually, we're not making fun of you. We're actually quite hopeful that your emphasis on integration and your learning from the things that we haven't done right will actually leapfrog you over us. So I think that there's an optimism and a watchfulness about what's going on in Ontario, and especially in parts of Ontario that are more changeable than others, that we will look to as examples. We've made people richer in healthcare. It's because of the ostensible, and I will get to that later, health human resource shortages. We've actually given professional bargaining units an enormous amount of power, and they've taken it. We've also started reforming primary health care. We heard some spectacularly innovative examples of that today, which I hope will be, again, an inspiration to you. And we've sort of gingerly, and in a pathetic Canadian way, slowly in an underfunded way, gone down the electronic health record information technology route, which underpins every successful health system transformation. But we're getting there fairly slowly. So this decade of $82 billion more has not been, I would say, an unmitigated success. So here are the solutions that most people talk about now when we talk about fixing healthcare, quote unquote. And again, there's nothing new here. The one that I find particularly intriguing, although it may merely suggest to you the dullness of my life, but entry to practice credentials has been a very interesting innovation, quote unquote, in Canada. I sit on a federal provincial committee that's trying to address this issue. As each profession adds a new entry to practice credential, so we now have master's degree entry to physiotherapy and OT. We've had degree nursing and so on, formerly diploma. There is talk of pharmacists moving to a PharmD, et cetera, et cetera, et cetera. We are actually boxing ourselves into some very interesting corners, and the question is, well, are these higher credentials going to get us anything in terms of quality, productivity, accessibility of care, and so on? And I think the preliminary answer is there's no evidence to suggest that they will. So do we have a shortage of doctors in Canada? Put up your hand if you say yes. You know, only 6 of you? I don't have to give my talk then, you're all tuned in. Well, of course, people think we do have a shortage, and the projections are even more shortage, and there's several million Canadians who can't find a family doctor. We have, interestingly, have about 200 geriatricians in the country, and we have 2,500 pediatricians in the country, when we have a lot more sick old people than sick young people. Nobody is going into specialties like rheumatology, where the need is greatest. Nobody's going into geriatric psychiatry. They have no trouble filling the dermatology residency positions and the radiology ones. And this is perfectly correlated, well, not perfectly, but it is reasonably well correlated with how much money you can expect to make as a physician. A colleague of mine at the University of Calgary can draw you a very nice graph that correlates the likelihood of filling your quota of residency positions in any specialty and the expected annual income of that specialty. So, as Berwick would say, we've designed the system not to have any geriatricians and rheumatologists, and we've designed it to have lots of dermatologists. So if your main problem is skin lesions, you're in good shape for the future. In any case, it's very peculiar about this doctor business and how many we have. And if you look at the literature, and you look at Canada, you will see that cities that have a very, very high physician-to-population ratio, like Vancouver, also have a high number of people who say they can't find a doctor. So it doesn't seem to be a numbers problem. It seems to be a distribution and access and inclination to seek care problem. We also, even though we've been talking dire shortages in the last few years, we have as many docs as we did a decade ago, and in fact, they're doing more service. I mean, some of them are not, but more services are being provided. And if you look at doctors, nurses, and any other health category internationally, and you compare the ratio of those in the population to population health status, there's no relationship whatsoever. So this is just an illustration of that. You can see this graph. The light blue bars are life expectancy in all those various countries, so don't worry about the names of the countries. On the left-hand side are the OECD countries, so we're in there. And you can see it's about, begins from 80 and descends on down. And then on the blue, the one that looks like a very serious ECG, is the physicians per capita. And what's interesting is on the left side of the graph is the variation.